So please mute yourself, but always show your video picture. Sign in your name, FB account, or email address in the chat box. Include names of companions attending. Okay. So use the chat box to ask questions and make comments while the pep talk is on. There'll be group picture taking at the end, at the start, at the end of the talk. Okay. So as a reminder, please take the OLETE for Mastery of Learning and have a perfect score to get the certificate. Okay. Abet, please put the link in the chat box. Okay. So as a reminder, the OLETE certificates will entitle one to a voucher for ROJoson telemedical consultation, free medical consultation. Okay. So let's now have a group picture taking. Okay. So I bet you just have to do the picture taking because I won't be able to see all of you. Okay. 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 One.
Sir, excuse me, can somebody please get the picture? My video is also not working.
Your video is not working also?
Yes. Naka-steady lang siya.
Okay. So I'll see. Okay. So wait. 1, 2, 3. Okay. So okay. So I have a patient empowerment program in which I like to empower the lay people or patients to take control of the management of their health. There are 3 courses in the pep talk. I completed the core course on October 9, 2021. And then from October 23, 2021 onwards, I've been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in Medical Management of GOITER, Part 3. Okay, this is part of the health disorder course. Okay. So I'll try to empower you to have a better understanding of the fundamentals and generalities in the medical management of GOITER, Part 3. Okay. In Part 1, we took these topics. Okay, what is a goiter? What are the common types, causes, and then how common are the goiters? In Part 2, we tackled clinical diagnosis of goiter, paraclinical diagnostic procedures for goiter. So today we will be on Part 3. This will be on treatment for goiters and then health restoration and maintenance after treatment for goiter. So some definition of terms. Fundamentals mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. Whereas generalities, general statements of information, not covering specifics and details. And medical management, meaning diagnosis and treatment done by physicians. So let's start with treatment of goiter. Formulation of the treatment plan, okay, starts with the pre-treatment diagnosis. So after the clinical diagnosis, and then if there's a need for paraclinical diagnostic procedures, and after that, we end up with the diagnosis just before the treatment. So there must be a pre-treatment diagnosis that is as specific as possible to serve as a basis for the plan. So when you say specific, it must have the name of the disease causing the goiter or the name of the thyroid disease and the extent of the disease, especially in those with cancers. Example, the stage of the thyroid cancer. After formulating the pre-treatment diagnosis, including the determining the extent of the disease and other factors which may affect on the treatment, first thing to do before considering comparing the different options of treatment is to spell out the specific objective or goal of the treatment. For cancers, thyroid cancers, whether the goal is curative or palliative, and for non-cancers, whether it's still curative or just control. Okay. For non-cancers, this means that for non-cancers, there are instances in which you cannot really cure. Okay. After the physician has decided on the goal of the treatment, he gives or lists the various options of treatment and then gives data on the BRCA. So with the data given, the patient is asked what or she prefers. Okay. So this is the table that shows the BRCA. Example of a BRCA comparative analysis of treatment procedures, option 1, 2, 3 in the first column. And then in terms of the benefit, which means the goal of the treatment, okay, well, okay, in terms of survival, which has the greatest survival? Example here, option 1 has the greatest survival rate. The list is for option 3. And then assuming that all the risks are acceptable, and then the costs are enumerated here, okay, and then assuming that they're all available, then the physician will recommend what will be chosen, or the patient will have to decide what will be chosen. So the best option here is if you put priority on the goal benefit with the greatest survival rate, this should be the option that should be chosen. And the cost is only 5,000 compared to 6,000 for option 2. Another example of BRCA analysis, option 1 has the lowest recurrence rate. So this should be the best option among the three, okay, with the cost is 5,000, okay. And then another example, in terms of benefit, this is the most effective, okay, in terms of cure, in terms of control, okay. So then with the least cost, 2,000, so this will be the option that should be chosen. So the usual goals of thyroid cancer, we'll now start with thyroid cancer. The usual goals of thyroid cancer treatment includes eradicating the known or visible tumors or cancers completely, entirely, preventing recurrence or spread of the primary cancer. Okay. And, or it could be, this one is curative goal, okay? You eradicate all known tumors. While as in the palliative goal, you cannot remove everything. You have exhausted all the curative approaches, no? But what you want is just to relieve the symptoms, okay? At the time of the treatment, the patient may present in a cancer stage in which the goal is at best palliative only, relieving symptoms. So these are usually in patients with advanced cancers, okay? Huge cancers, far advanced cancers that curative treatment is not possible anymore. For patients presenting with early stage cancer, the goal is curative, that is eradicating the tumors and cancers entirely and preventing the recurrence or spread of the primary cancer. Thus, the objective of the treatment is primarily dependent on the stage or the extent of the cancer at the time of treatment. So we're talking about thyroid cancer here. There are 4 common types of thyroid cancers: papillary, follicular, medullary, and anaplastic carcinoma. So for curative goal, okay, the primary treatment modality is an operation. It has a good success rate, okay. It may be followed by a radioactive iodine therapy, okay, giving a radioactive iodine substance. And then it can be followed by medical suppressive therapy using levothyroxine or thyroid hormones. Okay. So these are the usual treatment for patients with the curative goal. For palliative goal, the current treatment options that are being used are chemotherapy and radiation therapy. Operations for thyroid cancers usually consist of what we call thyroidectomy, meaning you operate on the thyroid, you remove the thyroid gland, either the whole thyroid gland or subtotal, means part of the thyroid gland, not the whole thyroid gland, okay? Then if the lesion is small, it's confined to one lobe, then you can do a subtotal. If there are lobes, there are nodules on the two lobes, right and left lobe, then we will be forced to do a total thyroidectomy. Okay? And then if there are lymph nodes, neck nodes on the side of the neck, then neck dissection will have to be done. There are different kinds of neck dissection depending on the extent of the neck node metastasis. For non-cancer goiters, okay, we now go to non-cancer goiters. Basically, there are two types: goiters with functional disorders and goiters with non-functional disorders and benign conditions. Okay, under the goiters with functional disorders, these are basically hyperthyroidism and hypothyroidism. So how do we treat them later? We'll discuss this later on. So the other group of non-cancer goiters are those with non-functional disorders, meaning no hyper, no hypo, and it's a benign condition that is not classified under cancer, okay, and not classified under functional disorders also. The goals of treatment will be either curative versus control, okay. So some don't recur after treatment. So that means it's curative, but some do recur, okay? So we just call it control, okay? But usually it's not life-threatening, okay? So only time will tell whether it will be a curative goal in treatment or a control goal in the treatment, or the outcome, whether it's curative or control, okay? So just like, unfortunately, just like in cancer, okay, even for non-cancer goiters, there's no guarantee for cure, okay? So the patient may need some lifetime maintenance medications, okay? So let's start with hypothyroidism. The primary treatment for hypothyroidism is medical therapy. So we just give replacement therapy in terms of thyroid hormones, usually the so-called levothyroxine, and usually lifetime. Okay? So no operation should be done, as this will just aggravate the hypothyroidism. Because with operation, you remove the thyroid gland, so more thyroid gland is removed, so you will have less tissues or thyroid tissues producing thyroid hormones. Therefore, you will be ending up with more severe degree of hypothyroidism. For hyperthyroidism, this time, kanina hypo, ngayon hyper, there are three options for goiters that are small to moderate. So we have to classify the hyperthyroid goiter into small, moderate, and large. Okay, for the small and moderate, there are three options: medical therapy with anti-thyroid drugs, operative therapy, and radioactive iodine therapy. Okay. But for those with huge size goiter, in which no amount of, even if you can control the hyper functioning of the thyroid gland with the anti-thyroid drugs or radioactive iodine, the size of the goiter will not reduce in size. It will just still be evident. So that's why operative therapy is recommended for the bigger goiters. For the colloid adenomatous goiter, this is another category of non-cancer goiters, usually due to some physiologic and degenerative changes. Okay. There are four categories: diffuse colloid adenomatous goiter, in which the two major lobes of the thyroid glands are enlarged, no nodules, okay, but still benign. Colloid cysts, there's one or two nodules which contain fluid, which is the colloid. Okay. Then solitary colloid adenomatous goiter or nodule, just one solid nodule. It can be mixed because of the colloid. Okay. And then multiple colloid adenomatous goiter. So these are the four categories that we can see in patients with colloid adenomatous goiters. Okay. So the treatment options for colloid adenomatous goiter: one, you can monitor without medications. The other option is give levothyroxine. okay, as a trial, okay, hoping it will decrease in size. And then the other option is an operation. So the third option, which is an operation, is recommended for huge size goiter. As I said, no amount of medical therapy will decrease the huge goiter into a smaller size. No? Okay. So but for small to moderate ones, no operations. You just monitor without meds and with meds. Okay. So sometimes, or a lot of times, all these nodules, colloid adenomatous nodules, do not completely disappear, but it poses no danger. So you just keep it there, just monitor. So it's important to have surveillance or monitoring for these non-cancer goiters. As I said, some don't recur, but some do recur. Only time will tell whether there will be recurrence or not. Okay, so it needs a lifetime monitoring. Okay. Then, as to post-treatment health restoration and maintenance after treatment of any type of goiter, whether cancer or not cancers, okay, there must be surveillance. Okay, as I said, more so for cancer, you need to, because of the higher chance of recurrence posing problems, you have to monitor, do surveillance for all these cancer patients, particularly. Okay, but there are instances in which the non-cancer goiters can also recur, so you still have to monitor. So the advantage of early detection of recurrence is that you can institute early treatment, and then you will have a better outcome. Patients may be taking maintenance medications for control of disease, and it may be lifetime. Okay. Usually, this is for both cancer and non-cancer goiters. Patients are advised to have healthy lifestyle to promote health restoration and maintenance. Okay, this is the best bet against recurrence. Okay, so except for anaplastic thyroid carcinoma, this is the fourth, one of the thyroid cancers being seen in the Philippines also. Fortunately, it's rare. Okay, so but for anaplastic carcinomas, which carries a very, very poor prognosis, okay, and those with very far advanced cancer, especially those neglected cancers which were not treated right away, even though it's follicular or papillary or medullary, okay. So usually the prognosis is bad, but the others, the early stage, the papillary, follicular, medullary, early stage thyroid cancer can still have a long life after treatment. Majority will have a long life after treatment. So summary takeaway. So I have discussed the fundamentals and generalities in the treatment of goiters. And then I also have give you some pointers on the health restoration and maintenance. So that's part of the part 3 of goiter lecture. So takeaway in relation to patient empowerment. Be always in touch with reliable medical information on fundamentals and generalities in medical management of goiter. Knowledge is power. It gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of goiter. So this ends my pep talk. Okay, the last of the series of this series, goiter, management of goiter. I hope I have empowered you to have a better understanding of the fundamentals and generalities in medical management of goiter. Part 3 means the treatment, and then the health restoration and maintenance. Okay. So with that, we end this lecture. So before we go to the open forum, as a reminder, please take the OLETE for Mastery of Learning. Also, try to get 50 OLETE certificates so that you will have a voucher for an ROJoson telemedical consultation. I think we are now on the 35th, okay, pep talk. Okay. So let's now have a group picture taking before we start the QA and interaction. Please turn on your video. I'm sorry, I cannot turn on my video. I try it again. Ayaw talaga. Okay. Okay. 1, 2, 3. Wait, huh? Again, let's try it again. 1, let's try it again. 1, 2, 3. Pahabol si Jen. 1, 2, 3. Okay. Okay. The floor is now open for questions. Okay. Anything that you want to ask? I hope I can hear you. So, how many have goiter here?
You can see you now, Doctor. You can see you now.
I'm using the other. I'm using the other. Can you hear me?
Yes.
Okay. Any questions?
None at the chat box.
So, as I said, how many of you have thyroid at the moment? Can you share with us your experience? Ida, of course, we know Ida. Ida has papillary thyroid cancers. Is I think more than 32 or 33 years in remission. Okay. She underwent thyroidectomy and neck dissection. Okay. So fortunately, there were no residual complications. Okay. So I have to mention that doing operations for thyroidectomy is not also easy. It has inherent complications like hoarseness of voice, okay, and then hypoparathyroidism, okay, in which the parathyroids, because it's so small, these are located behind the thyroid glands, and sometimes it's difficult to preserve, no matter how good the surgeon is. Okay. So then the other complications, of course, bleeding and also infection, but these are very, very rare. So what is more alarming are the hoarseness of voice and also the hypoparathyroidism. Usually when you have hypothyroidism, this is hypopara. This is not hypothyroid. Hypoparathyroid, no? Okay. So hypoparathyroid, you usually experience some cramps, some stiffness, okay, after the operation. Okay. So you're given calcium supplement, okay, to eradicate or to decrease the stiffness, spasm. No? So fortunately, or hopefully, sometimes these are transient. No? Usually within 2 months, 3 months, it will disappear. But in some instances, might be permanent. No? So you may have to take calcium supplement for the rest of your life. No? Okay.
Doctor, there is a question at the chat box. Hi, Dr. Joson. This is from Maria Justa Polotan. Hi, Dr. Joson. Can shoulder pain be a symptom of thyroid disease or thyroid cancer? Thank you.
Shoulder pain?
Yeah, shoulder pain.
The symptoms, okay. Now, okay, the first thing that you do is palpate the thyroid gland first. Okay. If there is an evidence of goiter, okay, goiter means enlargement, okay, or nodules, no? Then you can start thinking about the relationship of the shoulder pain to the thyroid disease of goiter or thyroid cancer. But if there is none, you don't see any goiter on the neck, no, whether it's benign or malignant. So usually it's not related. It's not a symptom of the shoulder's pain. It's not a symptom of the thyroid cancer. Okay? So the shoulder pain usually wala namang symptoms yung mga thyroid cancer except those which are malalaki na sinasakal ka na, no? Okay. Hoarseness of voice, you know, but shoulder pain medyo malayo unless talagang meron ka ng mga bukol sa neck. Bukol sa neck. As a symptoms, bihira yung ano. It's not a cue for thyroid cancer shoulder pain. The cue for thyroid cancer is that you have a lump, you have a mass on the thyroid gland itself, or you have a lump on the side of the neck, which could be a metastasis, you know? Or you have a lump on the neck with hoarseness of voice, hoarseness of voice, meaning the nerve has been invaded by the thyroid gland, by the thyroid cancer. Okay.
Is thyroid genetically inclined?
Pardon?
Is it genetically inclined? Is it also in the genes? It can be inherited?
Yeah, it can be. Thyroid cancer, as I said in my last lecture, it has genetic predisposition. Huh? Whether either goiter or non-cancer goiter and cancer goiters. For the colloid adenomatous goiter, there was a question last time, well, how come it's very common in females, diba? Okay. So usually it's very common in females because of, I think, because of your, what do you call that, stressful life as a female, okay? Because of your pregnancy, because of your a lot of things that you have to do for the family, you know, so you have a lot of stress, you know. So then, but for the others, like papillary cancer, you know, and medullary cancer, medullary is one of the most common cancer that has a genetic predisposition, okay, compared to papillary. Papillary, it's more of exposure to radiation. But in the end, the specific cause, in majority of cases, we don't know. No, we really don't know. Any more questions?
Can it be acquired?
Which one?
Goiter, can it be acquired? There are two, diba? As you said, there is genetically inclined and it can be acquired. Can thyroid be acquired?
Yeah, it can be acquired. Number one, because of when you say acquired, it develops after not related to the gene. So if you have insufficient iodine intake, then you have iodine deficiency goiter. But nowadays, it's not common anymore. Diba? Kasi maraming mga pagkain ng iodine-rich na fortification. No? Okay. The other one is another example of acquired goiter or thyroid, usually leading to thyroid cancer, is when you are exposed to excessive radiation on the neck. The radiation, let's say 1 month, or how long? 1 month of radiation on the neck, no? Usually for other causes, for other reasons. Let's say lymphoma on the neck, then because the better option of treatment for lymphoma is radiation. So the patient will have to undergo radiation. So after radiation, probably 5 years, 10 years, 20 years after, he might develop a thyroid cancer. So yan ang kapalit. ganun din yung mga, another example, yung mga acquired thyroid cancer, yung mga, yung mga tao sa Russia, yung Chernobyl disaster, di ba? Yung exploding, yung nuclear plant. Na-expose sila sa nuclear, yung substance. So a lot of them will have thyroid cancer. So it can be acquired.
There is a question from Perla Pasqua. Considering that I had been operated total thyroidectomy, why is it that my TSH sometimes is normal and sometimes it is high? It's fluctuating. What might be the reason behind it?
A lot of explanation that can be forwarded. Number one, okay, are you taking medicine? No, that's one. Okay, if you're taking medicine, it might fluctuate. No, okay. Number two, when you say total thyroidectomy is supposed to be all the thyroid glands are removed, so your TSH should be high because you have hypothyroid. If you're not taking medicine, no? Okay. So, but sometimes, okay, in the surgical world, when we said about total thyroidectomy, sometimes it's not the real total. It's assumed that everything was removed, but sometimes it's not everything that has been removed in terms of the thyroidectomy. So, but basically, I think it will be laboratory factors already. No? Okay. As I said before, be wary of the TSH interpretation. No? Okay. TSH is not, sometimes it may not be accurate. No? It will fluctuate. No?
Okay, there is another one from Ma'am Jacqueline Tong. Are certain races more predisposed to goiter? Example, Asians, Caucasians.
Predisposed, yes, meron. No? Okay, a very good example is yung thyroid cancers. No? There are 4 types. Okay, 4 common types, but iba-iba ang frequency. No? You have the papillary, which is most common, 90% at the time, papillary. Then you have follicular, probably about 40%. Then you have medullary thyroid carcinoma, okay. Then you have anaplastic carcinoma. These other 2 are not so common in the Philippines. No? Okay. Now, in the US, medullary carcinoma is more common. So we talk about Caucasians. No? They have more. Medullary carcinoma is more common than in the Philippines. So Asian. No? So bihira yung medullary carcinoma in the Philippines. Actually, 1% lang. This is US. The reported incidence is about 20–30%. No? Okay. So that's an example of may effect on race. No?
Okay.
The rest, the others are the same na. Let's say, sa America, ganun din. In the olden times, maraming iodine deficiency, kaya may goiter. No? Then, in the Philippines, in the olden days, maraming pagkulang sa iodine, so maraming goiter. Okay? Pero ngayon, tabla na. No? Okay, para na. No? Wala na. No? Okay, any more questions?
Nothing at the chat box.
Who likes to share their experience pa? We still have 4 minutes. Now, yung MCAG, let's talk about the colloid adenomatous goiter, now, which is very common. No? That, yung mga thyroid cancer is not so common. As I said, mga 5% lang. Ito, 90 to 95% are colloid adenomatous goiter. No? But a lot of times they present as nodules. No? Nodules. Kaya when you have nodules, you start thinking, is this cancer or not? No? Okay. So be wary of all the tests because as a the tests are being done to distinguish whether it's really benign or malignant. Now, there are a lot of tests, so be wary of the ultrasound report. Pag pinapa-ultrasound, no, there's a tendency to overdiagnose by the radiosonographer. Sasabihin, ay, baka cancer. Ano, no? Okay. At sinabing baka cancer, if you end up with a doctor who will who have a mindset that, okay, baka sinabing baka cancer, ano natin, we pursue it. Now, we pursue it either by doing an operation, by doing a needle biopsy. No? Okay. So just be wary of those possible scenarios. No? Okay. So, but usually pag MCAG, okay, usually benign lang siya, you can keep it there. You don't have to have it removed. Okay, matakot. No? Okay. So you just observe. Okay. So the common fear of mga Filipinos is that once you have a nodule, may bukol, no? Nakakatakot, patanggal ko na kaya. No? Okay. Okay. So, pwede pang i-observe kasi very uncommon naman yung thyroid CA papillary. No? You just monitor. Okay. Is there a correlation between AIDS and thyroid cancer among women? Yes and no. Let's put yes and no. Kasi papillary cancer can occur in the earlier age, no? Kahit na bata, no? Okay. Papillary at any age, no? And then, yung anaplastic carcinoma, okay? Anaplastic, one of the poorest cancer with the poorest prognosis occurs in the 50 years and above, usually ganun, no? So, pero let's say if you are 50, 70, no, if you get a thyroid nodule, it turns out to be cancer, majority will still be papillary. Okay, majority. So, the moment you just have to look at the behavior of your thyroid nodule. Let's say you have a 50 years old, 70 years old, malaki bukol, mabilis lumaki, sinasakal ka na, that's anaplastic carcinoma. No? So, mahirap na talagang habulin yun, anaplastic carcinoma. Okay, any more? It's 3 o'clock, exactly 3 o'clock. If there are no more questions, last call.